Good morning, everyone. Everybody can hear me? Welcome. It's an early start, I appreciate it. But thank you for coming. My name is John Marley, and as of yesterday evening, I'm the new Dean of the Faculty of Dentistry at the Royal College of Surgeons of Ireland. I'd like to take this opportunity to welcome all of you, either those of you who are attending today in Dublin, and to our family of friends and colleagues across the world who are joining us through our streaming facilities. This is, as you know, our intensive revision course for those preparing for the Diploma or MFD, or even thinking of undertaking the exam in the future. And I know a lot of the audience are also undergraduate, senior undergraduate students, so that would hopefully help you in your preparation for your final exams. You're all most welcome. This is clearly a very intensive course, as the name would suggest, so there's a lot of work involved. On the other hand, hopefully it will be of benefit to you and you will get some enjoyment out of it, if enjoyment is the right word. So you're all most welcome. I'd like to introduce now Dr. Albert Lung, who will take us through this morning's agenda. And as I said, I hope you all enjoy the course today. Thank you very much.
Thank you very much, John. Good morning, ladies and gentlemen. Good morning to our colleagues from the Middle East and the Gulf region as well, who we are streaming to. You're all very welcome to the program here this morning and this afternoon as well for the intensive revision course. The program this morning is that we're going to start off with the overview of the Diploma, MFD, as well as the primary care pathways by Dr. Cowan. And then we're going to go into different categories of the areas of the examinations that we're going to address this morning. At about 11 o'clock, we'll have a half an hour or so. We'll go run through some sample questions, some tips of what may come up in different aspects of the exams. And then we go on to the second categories of our lectures this morning before we come to lunch. After lunch, you come back for more of the same, but we are here to try to address as much as possible the areas of the syllabus that you may find useful in relation to the MFD examinations and in relation to the diploma examination as well. So without further ado, if I could ask Dr. Peter Cowan, who's going to talk to us about the overview of the pathways that we have. Thank you very much.
Thanks, Albert. Morning, everybody. Thank you for coming today. And I can say to our Middle East and Gulf friends, Salam Alechem. You're all very welcome this morning, and I hope you're going to enjoy this. As Albert and John have already told you, this is an intensive course, so there's going to be quite a lot of information coming at you this morning. So the first thing I'd like to do is to give you a little bit of an overview of what's coming, and to give you some background into the examinations themselves and the training program that's available here throughout the college. So in terms of the intensive revision program itself today, we're going to have a series of 25-minute extremely focused lectures on a variety of different topics that you've already been able to see on the program. As Dr. Leung has already pointed out, the lectures themselves will guide you towards the upcoming examinations, the Diploma of Primary Care Dentistry, the MFD Parts 1 and 2 examinations. And throughout the day, there will be an opportunity to see multiple choice question examples, clinical reasoning assessment type questions that are relevant for the diploma, single best answers, and we'll show you one or two OSCEs as well, the objective structured clinical exams. So there will be an opportunity to review the type of question that you might receive in an examination. So before we look at the intensive overview, just a couple of housekeeping points. Please make sure your mobile phones are switched off. It makes life an awful lot easier for all of us. Take a note of the exits around you. And just to remind you that there will be coffee and tea breaks mid-morning, mid-afternoon. There's a lunch break as well around about 1 o'clock. Now, unfortunately, we're not providing lunch for you, but we will provide you with coffee and tea and lots of sugary things outside to keep your glucose levels high throughout the morning. So I'm going to begin by just giving you some background on the Diploma of Primary Care Dentistry, the first examination. So it's an RCSI exam and qualification, and this particular examination is only held in Ireland. And I suppose it came about some years ago when we in the faculty felt that the examination, the MFD Part 1, wasn't doing what we wanted it to do for Irish graduates. It wasn't, if you like, fit for purpose in that way. So as part of our review, we had quite a number of the major primary care stakeholders involved to see could we make this examination more user-friendly and more relevant for an Irish group. And so we came up with the Diploma of Primary Care Dentistry, which is now, I think, in its third or fourth year, possibly even its fifth year. This is an examination which is approved by the Dental Council, who had quite a lot of input into it. And the good news is that the Diploma of Primary Care Dentistry shares an equivalence with the MFD Part 1. So who's eligible for the diploma? You've got to be 6 months qualified, and you must have completed 25 hours of continuing professional education within the previous 6 months. Now, you're probably all aware of the Dental Council's annual requirements. At this time, they're still voluntary. They're not mandatory at this point, and they won't become mandatory until eventually we get a change in the Dental Act. We haven't had one since 1985, so we're well out of date. But there will come a time not too far in the future whereby all continuing professional education will be a mandatory requirement. And it's useful for you to have a look at the Dental Council website. For the 50 CPD points that you will require each year, 20 of them should be verifiable, and the other 30 will be general CPD points. But in terms of eligibility for the diploma, we're only asking you for 25 CPD points. You should also be aware through the Dental Council guidelines that some of the CPD points should be in areas that are called core CPD. So when you look up the website, it will give you a very good guideline as to what you require. Now, part of the change of both the diploma and the MFD Part 1 was that previously it had quite a lot of irrelevant basic science in our view. So we've now changed it over the last number of years so that it has 20% approximately of relevant basic sciences. Relevant being that it's relevant to your day-to-day clinical practice, in our view anyway. It may not be in your view, but it is in our view. And 80% of the examination is now clinically based. It has a clinical relevance to your day-to-day lives. However, it is a very wide syllabus, and it does cover all the various disciplines within dentistry. So your guideline to help you prepare for this examination is through the syllabus and through the learning outcome documents that you'll find on the faculty website. I keep referring to it at the bottom of the page. It's the same slide going up time after time. But if you go onto the faculty website, you'll be able to hook into the diploma. And there are a number of very good learning resources which will help you prepare. I hope this today being one of them. The faculty also holds a postgraduate dental education program once a month for 8 to 10 months of the year. There are many other very good programs and CPD opportunities both in the north and south of Ireland, the Irish Dental Association being one of them, and there are many others. The diploma itself is held twice a year. The next diet is in April of this year. I think it's April the 3rd, Albert, if I'm correct. April the 3rd, it's the first Monday in April, and it's also held the first Monday in October each year. And for the diploma, there are 2 papers. One of them is a multiple choice question paper with 75 questions on it, with a stem and 5 different branches. The answers are true or false, so there are 375 questions, true or false answers, and you've 2.5 hours to complete, which actually is plenty of time. It sounds like a lot, but it's plenty of time. There's no negative marking, so you're encouraged to try every question, even the ones that you're not sure of. It's worth your while having a go. You have a 50% chance of getting it right if you go along. The second paper then takes place on the same day. This is one of the newer parts of the diploma. This is the clinical reasoning assessment paper. And this will set out some clinical scenarios for you that you might come across every day in your practice, and there will be related questions to that. Dr. Leung will go through some of these examples with you as the day goes forward. And in addition, there are 10 CRA, or clinical reasoning assessment questions, plus 33 single best answer questions on paper 2. There's 50 minutes for each section, so 100 minutes for the second paper. And all of this should be well within your grasp, well within your grasp. So to finish up on the diploma, it's a standalone qualification. It is registrable with the Dental Council here in Ireland. It allows exemption from the MFD Part 1, and once you've completed the diploma, you can go straight to the MFD Part 2 once you've completed all the other requirements as per the regulations. Now, if we look at the MFD Part 1, and this will be for some of the people who are watching in the Middle East and Gulf region, for the people in the UK and outside Ireland, essentially, there's a single paper, one single paper. And this is a 3-hour paper, but it combines 75 MCQs with 20 single best answers. So it's a slightly different format, but it does achieve the same result. So having completed excuse me, either the diploma or the MFD Part 1, you're now eligible to think about doing the MFD Part 2 should you wish to do so. This time you've got to be qualified for a minimum of 12 months, and you must have been practicing dentistry for a minimum of 12 months. And now, instead of 25 CPD, you need 50 hours of CPD for that year. That makes sense. It's just double the time, double the CPD requirements. For those of you who may have completed a house officer post or some recognized training post, you are exempt the CPD requirement if you've completed 6 months training. However, the likelihood is that those of you who may be on a 6-month program, you probably will also have done the 50 hours of CPD. But it is a slight little extra for you. The Part 2 is a mainly clinically related format. There are 17 OSCE stations, 14 of which are scoring stations, and the examination in general takes about 90 minutes. There is, at the present time, a mandatory CPR station. We flag this for you because everybody has to go through a CPR demonstration. You will be given one as things stand at the moment, so you need to be well versed in demonstrating good CPR technique. In addition to the OSCE, there are then 2 15-minute general oral examinations. So it means that you'll have 2 pairs of examiners, and all of the examiners will come from different backgrounds. So for instance, you might have an oral surgeon and a prosthodontist on one side, you may have an endodontist and an orthodontist on the other side, but it's the luck of the draw who you sit in front of. But you'll be asked questions then from each of the different areas, and it will be quite a general type of viva. We're not looking for specialist knowledge at this stage, but we're looking for levels of excellence in a general way going through. So again, the clinical side of this, the orals, the Part 2, should be something that will be easier for you to some degree because you'll be doing this in your day-to-day practice all the time. So an example of what I might call, in inverted commas, a knowledge-based OSCE station. You could, for instance, see a slide like this when you arrive at one of the OSCE stations. A picture of the upper right quadrant with a number of teeth present, clearly some restorative procedure going on, and there may be a series of questions that are graded in a certain way. For instance, what are the indications for a CAS post-restoration? Well, we know it's for an endodontically treated tooth, and there are other requirements for endodontic, for CAS post-restorations. You can see the type of question that may occur for you. And again, we will go through these in a little bit more detail when Dr. Leung does the practice sessions. But that's the sort of thing I think all of you sitting in the audience would have no difficulty with a question like this if it presented in the examination. So when are you eligible for the award? Well, you're eligible for the award of the MFD if you have a recognized primary degree, and presumably you would have had that in your initial eligibility for the Part 1, and you must be successful in the Part 2. It's as simple as that. So if I can summarize the potential training options that we see available here within the college along a primary care pathway, because about 90% of you who will qualify will go into primary care. There's probably about 10% of people who eventually go into specialist practice. Most people start with the diploma, and that's generally taken within the first 12 months of qualification. You then have an opportunity to go on to look at the MFD Part 2, usually within the first 2 years, but of course these are only guidelines. Anybody can come in at any point on this line, and you may choose to stop there and do no more. But there are other opportunities for you if you're interested in pursuing a training pathway. It's all set out. It has been there for many years. All of these are registrable qualifications with the Dental Council. And the new membership in general dental surgery examination, I say new because I stood here this time last year and I said to you that there would be some changes in the MGDS. There are now changes made, and we will be launching a new format MGDS very shortly through the faculty. Keep an eye out on the website. And this is going to be a lot more user-friendly. And this is a really terrific examination. And this really looks at a very high degree of excellence in primary care throughout the disciplines. So this is something that you can prepare for within your practices. You don't necessarily have to take time off. We have a lot of study resources here through the college that we can aid you along should you wish to be involved. And finally then, in that pathway, there is the potential to go on to fellowship level should you want to do this. So in summary, in terms of training options, examinations, and overview, we would suggest that having qualified, you might consider within the first 2 years the diploma and then the MFD. This seems to be the common core pathway that probably most people are doing now in Ireland when they come out of university, because it gives you options. You can go to the right or to the left of this pathway. If you go down the left-hand side, you're going down the primary care route. And this is the MGDS pathway, and then on to the FGDS if you want to. So there's a whole 7-year package, in inverted commas, if you like, to keep your interest up. And, you know, examinations were things that we always shunned a lot. We don't like the look of them, and who wants to do an exam when you're finished? But it's great to keep your brain active, to keep yourself up to date with what's going on, and to challenge yourself and validate your learning by some method. And this is a great way to do it. And we'd certainly be around to help you and give you as much advice as we can. Others may choose to go down the right-hand side of the pathway, and that's the specialist training option. And here you'd have to choose a specific discipline, and you'd spend 3 years in a full-time post in an approved institution, approved by the faculty, before you sit the final FFD, the final specialist fellowship examination. Okay, so that's a very rapid overview of the examinations themselves and also the potential options for you in training pathways. Now, the good or bad news for you is that the first speaker this morning is also me. So if you give me a moment, I'm just going to make some changes here, and we'll get into the program proper. Hopefully we'll be starting anyway. Okay, now I think all of you should have a handout. Those of you who are watching us live on the live stream, you won't have a handout in front of you because we haven't been able to physically give one to you, but we can put it up on Dropbox along with the other presentations that we'll be following today. They'll probably go up early next week, so don't worry if you don't have the handout in front of you. So I'm charged with talking about head and neck anatomy for you this morning. And I suppose the reason why it's the first lecture on the program is because it's usually the toughest one for all of you, because it brings you back to earlier days. But I'm going to try and make it some interest for you this morning. And what I'm going to try and cover today for you are the bony landmarks of the skull. We're going to look at the anatomy of the temporomandibular joint. I'm going to dwell in some detail on the muscles of mastication. And today I'm going to cover 3 of the 12 cranial nerves, the 3rd, the 4th, and the 6th, which are relevant for eye movement. I would advise you, however, also to be familiar with the anatomy of the tongue. The other cranial nerves, you should certainly be aware of the 5th and the 7th cranial nerve in detail. And you should have a knowledge of the blood supply, the venous drainage, and the lymphatics of the head and neck system. All of this is at the bottom of your handout, so you should be able to make a move from there. So let's start by looking at the bony landmarks of the skull. And these are the relevant bony landmarks that I think are important to you. And if we start by looking at this large frontal bone here in yellow at the front, we can say that the frontal bone is separated from a pair of parietal bones in green at the top by the coronal suture. The coronal suture. At the midpoint of the coronal suture is a structure we call bregma, B-R-E-G-M-A, bregma. And bregma represents the anterior fontanelle of the child. Now you'll remember when a child is born at the beginning, the skull bones don't completely unite. The sutural bones are open to a degree. And this is to allow the normal growth and development of the brain. The anterior fontanelle, represented here by bregma, closes at around about 18 to 24 months. Let's move now from bregma posteriorly, and those 2 parietal bones, starting from bregma at the front, are separated down the middle by the sagittal suture, and that continues until it meets the occipital suture at the back of the skull at a point we call lambda, L-A-M-B-D-A, lambda. And similar to bregma, lambda marks the posterior fontanelle in the child. Now this one closes a bit earlier, usually before 6 months. As the sagittal suture approaches lambda, there are often 2 emissary veins present, one on either side of the midline. These are the parietal emissary veins, and they connect the superior sagittal sinus, one of the great venous channels inside the skull, with the occipital veins. The parietal emissary veins connecting the superior sagittal sinus with the occipital veins. Now, a brief word about emissary veins in general. Emissary veins are valveless structures that allow the 2-way flow of blood from inside the skull to the outside or from outside the skull to the inside. And I suppose they act a little bit like pressure valves to allow excess fluid, in this case blood, to be moved around from one side to the other. About 2.5 inches below lambda, you can see the external occipital protuberance. If you all put your hands behind your head in the midline and feel a little bump in the middle of the back of your head, that's the external occipital protuberance. Okay? On either side of that, are structures called the superior nuchal lines, N-U-C-H-A-L, superior nuchal lines. Now these are the surface markings for another of the great venous channels, the transverse sinus inside the skull. They also give rise to two important muscles. From the medial third, the trapezius muscle, and from the lateral two-thirds and the mastoid process, the sternomastoid muscle. Both of these muscles are supplied by the 11th cranial nerve, the accessory nerve. Let's move on to a lateral view now of the skull, and let's identify some other important areas. We left the coronal suture at bregma, and it travels down the lateral side of the skull to reach the upper border of the greater wing of the sphenoid, this pink bone here, at a point called pterion, P-T-E-R-I-O-N, pterion. We can identify the superior temporal line, and below it the inferior temporal line, and between the two, the area where the temporalis fascia attaches. Below the inferior temporal line is an area we call the temporal fossa. And the temporal fossa is appropriately fan-shaped because this is where the temporalis muscle arises. And we'll look at that in more detail in a moment. We can see the mastoid process, and above it another emissary vein, the mastoid emissary vein. And this connects the sigmoid sinus, yet another of these great venous channels, the sigmoid sinus, with the posterior auricular vein. We can see the external auditory meatus, and above it the suprameatal crest, which extends forwards as the zygomatic process of the temporal bone. The zygomatic arch is composed of three bones: the zygomatic process of the temporal bone, the zygomatic bone, and the zygomatic process of the maxilla. There's also a zygomatic process of the frontal bone, and so this frontomaxillary buttress is at the very front of the zygomatic arch. The zygomatic arch is prone to being damaged through trauma, and there are structures that are related to it that we should be aware of. For instance, along the lower border, we know that the masseter muscle arises, and the arch itself is crossed by branches of the facial nerve, and at its root, the auriculotemporal nerve and the superficial temporal vessels. We know that the superficial temporal artery is one of the terminal branches of the external carotid artery. Looking inside now through a sagittal view, just to identify some other areas that you'll remember: the frontal sinus, here's the ethmoidal sinus region, and with it the perpendicular plate of the ethmoid that you've remembered from before, the sphenoidal air sinuses and the sella turcica region, and the internal acoustic meatus. If we look underneath the skull now, the big black hole in the back of the skull, of course, foramen magnum, through which the spinal cord passes and the skeleton. The occipital condyles on which the atlas vertebra rests, and lateral to that, the carotid canal, through which the internal carotid artery passes. Lateral again, the styloid process. Three muscles arise from the styloid process: stylopharyngeus, styloglossus, stylohyoid, all with different cranial nerves. We know that there's a condition called Eagle's syndrome, spelt as you'd expect, E-A-G-L-E, Eagle syndrome, where there's calcification of the stylohyoid muscle. And it's a condition, it's not a very common condition, but it's a condition that might present patients having difficulty swallowing or moving their heads, and it requires surgery when diagnosed. Eagle syndrome. Lateral to the styloid process, the stylomastoid foramen, through which the facial nerve emerges, the seventh cranial nerve, from its bony journey. A few other foramina. Before that, the sphenoid, the spine of the sphenoid here, and just lateral to that, the foramen spinosum. Foramen spinosum transmits the middle meningeal artery and vein. Middle meningeal artery is one of the branches of the maxillary artery from the first part. And then the famous foramen ovale. And we love asking questions about the foramen ovale somewhere along the way. So the foramen ovale has 5 things that pass through it. Whoops. Apologies. So, the mandibular nerve, number 1. Its motor root, number 2. Remember that the mandibular nerve is a mixed nerve. It's the only mixed nerve in the trigeminal. It has both motor and sensory branches. So we have the mandibular nerve, its motor root. There's an emissary vein running from the cavernous sinus to the pterygoid plexus. That's number 3. Number 4, the accessory meningeal artery, another branch of the first part of the maxillary artery. And finally, the lesser superficial petrosal nerve on its way to the otic ganglion. Finally, in terms of bony landmark, let's look inside the skull now. And we know that there are 3 cranial fossae, anterior, middle, and posterior, and they're arranged a little bit like the steps of a ladder. In the anterior cranial fossa, it houses the frontal lobe of the brain, and its floor is at the level of the roof of the orbit. The middle cranial fossa houses the midbrain, and its floor is at the level of the zygomatic arch. It's a step down. And the posterior cranial fossa houses the brainstem and cerebellum, and its roof is housed in by tentorium cerebelli at the level of the zygomatic arch, and the tentorium is like a thin tissue which holds it all together. We can identify the cribriform plate of the ethmoid, the optic foramina, the foramen rotundum, the foramen ovale from the inside, the foramen spinosum from the inside, and the internal acoustic meatus. Okay? Now, let's move on from the bony landmarks to look at the anatomy of the temporomandibular joint. So we can say that the temporomandibular joint, formed between the head of the mandibular condyle and the glenoid fossa, is an atypical synovial joint. Atypical. Why is it atypical? Well, it's atypical for 2 reasons. Number 1, it's a paired joint. It's the only paired joint in the body. The left and right move together. And it's also atypical because the joint is separated into an upper and a lower joint compartment by the disc, a fibrocartilaginous disc. Now the disc is attached to the inside of the capsule, and its posterior lamina has a lot of elastic tissue in it to allow it to recoil when the head of the mandible, the head of the condyle, positions into the glenoid fossa. If you look at the disc from a sagittal view, which is what you're looking at on the pictures in front of you now, it was classically described as looking like a jockey's cap, with the main part of the disc sitting on the head of the condyle and a peak sitting forwards, which is the anterior lamina. So that as the mandibular head, as the mandibular condyle moves forwards, it slides down the posterior surface of the eminence along that anterior lamina. It facilitates the movement of the head of the condyle in a movement we call translation. It's not just an opening movement, but it slides down the eminence along that peak. if you were to look at the disc from a bird's eye view from the top, it looks a bit like a donut with the thick fleshy part around the side and sadly a bit like my own head, the thinner part on the top of it. Okay? You could come into a Viva examination and I might ask you, what are the characteristics of a synovial joint? Give me an example of the characteristics. So what I'd be looking for would be, first of all, in all synovial joints, there's a degree of congruity between the two parts of the joint. By congruity, I mean they fit into each other, ball and socket, the head of the condyle, the glenoid fossa. Congruity, we call this. Synovial joints in general have a synovial membrane, which, while it has no nerve supply, is very vascular. And it lines the capsule, and it's attached around the articular margins of each of the bones. All synovial joints have synovial membranes, and all synovial membranes secrete a synovial fluid, which is characteristically viscous due to the presence of mucopolysaccharides. And the example of this is hyaluronic acid. It contains a lot of different types of cell in the fluid, but they're mainly lymphoid and phagocytic. And the function of the synovial fluid is firstly to provide lubrication for the joint so it can move easily, and secondly, to act as a scavenger system to remove bits of debris that are there through phagocytosis. Keep it clean. All synovial joints have a capsule, and it's no different in the temporomandibular joint. The capsule is attached around the neck of the mandible to the undersurface of the eminentia, and more deeply then onto the medial surface, deep into the squamotympanic fissure. But the joint itself must be held together, and it's held together by ligaments. And the main ligament of the joint is this big lateral ligament of the joint, or temporomandibular ligament, which runs from the eminence to the neck of the mandible, with the deeper fibers of the ligament blending with the fibers of the capsule. There are two secondary ligaments of the temporomandibular joint, the stylomandibular ligament, shown here, running from the styloid process to the roughened area on the medial aspect of the angle of the mandible, and the sphenomandibular ligament running from the spine of the sphenoid to the lingula, the area just above the mandibular foramen. The nerve supply to the joint is the auriculotemporal nerve, and there are branches from the nerve to masseter and the deep temporal nerve. The blood supply through the superficial temporal vessels. And of course, synovial joints in general, and particularly the temporomandibular joint, they have to have muscles to make them move. They're just going to sit there otherwise. And so we need to describe the muscles of mastication. And if you're describing to me, if I ask you what the muscles of mastication are, you'll probably tell me there are 4 of them: the lateral and medial pterygoid, the masseter, and the temporalis. But you should always include the digastric muscle. It's an important muscle in opening movement. It's the initial opener of that joint, pure hinge movement. So we're going to look at those now in detail. The temporalis muscle arises from that temporal fossa that I showed you below that inferior temporal line, that fan-shaped area. It's a big, big fan-shaped muscle, and it collects into a tendon which attaches to the coronoid process, and it passes some way down the anterior border of the ramus. I've seen some traces of the fiber occasionally when I'm doing third molar surgery. It can sometimes get down that far. The nerve supply, the anterior division of the mandibular branch of the trigeminal nerve. Its action is, it's one of the good closing muscles of the lower jaw, but it closes and retracts the mandibular condyle. Lateral pterygoid arises two heads, the upper head from the infratemporal surface of the greater wing of the sphenoid, shown here. The lower head, which is the main head, arises from the whole of the lateral surface of the lateral pterygoid plate. The two heads converge on the neck of the mandible, and the fibers from the upper head insert into the disc. Its nerve supply is similar in that it's the anterior division of the mandibular branch of the trigeminal, and its action, lateral pterygoid's action, is to open and to translate the mandible down that eminence. And when it does that, it allows a wider arc of opening. That's the significance of lateral pterygoid. And you'll see the difference between it in a moment and digastric. But before that, the medial pterygoid arises again in two heads, the upper head from the maxillary tuberosity and the lower head from the whole of the medial surface of the lateral pterygoid plate. That's a bit of a mouthful. The medial surface of the lateral pterygoid plate. Now, its nerve supply is slightly different in that it comes from the main trunk of the mandibular nerve before it divides into anterior and posterior branches. The sort of trick question that might come up on an MCQ. What's the nerve supply of medial pterygoid? It comes from the main trunk of the mandibular branch of the trigeminal before it divides. Its action is to close the lower jaw. It's a powerful closing muscle. Not quite as powerful as masseter, which arises in three heads from the lower border of the zygomatic arch. We saw that earlier. The main head is the superficial head from the anterior 2/3, and the middle and deep heads arise in continuity with it along the remaining part of the lower border of the zygomatic arch. Its fibers pass downwards and backwards to insert into the angle of the mandible on the buccal side, the lateral side, and the fibers interdigitate with the fibers of the medial pterygoid. So you have this fantastic pterygomasseteric sling, if you like. When you close your jaw, those two muscles are pumping it up very tight for you. Its nerve supply, again, the anterior division of the mandibular branch of the trigeminal. And here is little digastric. So this arises in two heads. It has two heads. The posterior belly arises from the mastoid process, and the anterior belly arising from the mandibular symphysis. And they're connected through a little intermediary tendon here that connects to the hyoid bone. The nerve supply is a little more interesting in that the posterior belly is a second arch muscle. Therefore, its nerve supply is the facial nerve, the nerve of the second arch, through the posterior auricular branch. The anterior division is a first arch muscle, so it's supplied by the fifth nerve, the trigeminal nerve, through the nerve to mylohyoid. Now, I've just marginally over 2 minutes and 16 seconds left, so I'm going to run a tiny bit over with your permission, but I'm going to just cover these three important cranial nerves today. It is necessary for you coming into an exam of this level to have some sense of the cranial nerves. You should certainly be aware there are 12 pairs of cranial nerves. You'll remember that. I think it's important that you should be able to equate number and name. So, for instance, you should know easily that the 10th nerve is the vagus, or the 4th is the trochlear, or the 9th is the glossopharyngeal. You need to refamiliarize yourself with names and numbers. But the key nerves for you are the 5th and the 7th. That's the trigeminal and the facial, and the three we're going to do now. The first of which is the oculomotor nerve, the third cranial nerve. And all of the three nerves I'm going to cover with you in the next couple of minutes are involved in the movement of the eye. Okay? And the nucleus for the oculomotor nerve, it arises in the midbrain. and it picks up some sympathetic fibers in its journey from the area around the cavernous plexus. The internal carotid artery comes up very close to the cavernous plexus, cavernous sinus, and it's carrying sympathetic fibers with it. And these sympathetic fibers are picked up by part of the oculomotor nerve, the superior division, because it divides now into superior and inferior branches. All the nerves that enter the orbit to supply the muscles of the eye pass through the superior orbital fissure. There are 7 of them. I'm not going to go through those today with you, but each one you'll see today passes through, and this is no different. The superior branch of the oculomotor nerve then supplies the superior rectus muscle, and it also supplies the levator palpebrae superioris muscle. This is the muscle that lifts up and down your upper lid. And there's a condition called Horner's syndrome, H-O-R-N-E-R, Horner's syndrome, where there is a damage to the sympathetic supply. The sympathetic supply is damaged, and therefore the levator doesn't work, and you have what's called ptosis, or drooping of the lid, in Horner's syndrome. The inferior branch supplies 3 other muscles: the medial rectus, the inferior rectus, and the inferior oblique, as well as supplying the pupil, the sphincter pupillae, which opens and dilates and constricts the pupil. If you came into the examination and I asked you to demonstrate whether somebody's oculomotor nerve was working, how would you go about it? So let's pretend I'm the patient, and I'd want you to stand in front of me. You'd ask the patient to cover one eye, and you'd have a finger in front of my eye, maybe about 2 feet in front of my eye, at the level of the pupil. You'd be at the same level. So to demonstrate the 4 muscles of the oculomotor nerve, superior rectus, you'd ask me to look vertically upwards. For inferior rectus, vertically downwards. For medial rectus, we'd look horizontally medially. And for inferior oblique, you'd look upwards and outwards. Upwards and outwards. Most people think it's the other way around. Inferior oblique, upwards and outwards. Okay? The trochlear nerve supplies 1 muscle. It starts in the midbrain, passes through the lateral wall of the cavernous sinus. Again, it passes through the superior orbital fissure, and it supplies the 1 muscle, the superior oblique muscle. So again, to test the 4th nerve, hand over the eye, standing in front of the patient. This time the movement is downwards and laterally. Down and lateral, superior oblique. Okay? And the final one then is the abducent nerve, and these are my last 2 pictures. This is the 6th cranial nerve. Its nucleus is based in the lower pons, and it actually enters the cavernous sinus. And it is the last of the 7 nerves to pass through the superior orbital fissure. It's the most medial of them. And it supplies, again, 1 muscle, the lateral rectus. Another easy one. Cover the eye, finger in front, and for this eye, it's a lateral movement in the horizontal. Okay? So there are 6 muscles to remember. How will you remember them all? You'll remember them by this chemical formula, LR6SO4. You've probably seen it before, but we'll go through it again. Lateral rectus, the 6th nerve, the abducent. SO4, superior oblique, the 4th nerve, the trochlear nerve. All the rest are supplied by the oculomotor. And with that, I thank you.
Thank you very much. Thank you, Peter. Thank you.
This one, yeah. Patriot, yeah. And medical emergencies, yeah. My voice is not great. It's 20 minutes, is it?
Okay, ladies and gentlemen, we move on to the next topic, which is medical emergency, and we've got Professor Ekanayaki to give us the talk on. This is related to section 1.2 of the syllabus. So without further ado, Professor Ekanayaki.
Thank you. Good morning, everyone. I'm going to cover the medical emergency, which is a very important topic, regardless of whether you are a general practitioner or whether you are a surgeon or whatever it is. It's very important to know the